Yeah.
Yeah.
All right, so let's start with like our anatomy. I'm not going to be drawing here, but let's just start from the structures. So I'm going to start with the epiglottis at the very top, right? And we know that the epiglottis is what covers the respiratory system, right? So it's kind of over the trachea, and then it opens up when you inhale, it closes when you swallow, right? So it protects your entire respiratory system. And then right below that, of course, we have our trachea. And then below our trachea, we have our first your main stem bronchus, right? So that's our main airway. And then that main stem bronchus splits into your right main stem bronchus and your left. And then from there, so these are known as your primary bronchi. And then from your primary bronchi, it basically gets smaller and smaller, right? And then, so we'll put, these are primary, and then it becomes secondary bronchi. And then after secondary bronchi, again, it gets smaller and smaller, and then we have our tertiary bronchi. And then once we've gone through our tertiary bronchi, and then it becomes your bronchioles. So what do all of these structures have in common, do you think? The trachea, the main stem bronchus, the right and left bronchus, all of the secondary bronchi, tertiary bronchi, and bronchioles. What do they all have in common? Any idea? What do we consider them all as? What are they part of? Say again? Yes, the respiratory system. Yes. What else? Some of them, bronchioles may not be considered as upper respiratory because they're kind of at the very end, right? But is there gas exchange that happens in any of these structures? No. So what are they? Oops. What are they called? They're just airway, right? All of these structures, air just flows through them, right? There's no gas exchange that happens through them, okay? So they are all tubes, right? They're all tubes. So later on, as we talk about pathology and as we talk about like signs and symptoms, I want you to remember that, okay? These are all just airway. Why else is that significant? When you're looking at your ABCs, right? Yesterday we talked about prioritization of test questions, and we start with A. These are the structures where A would be an issue. So meaning if there's a problem with any of these structures, then that could be an airway problem. And that's your priority in a test question, right? And then we'll talk about lung sounds and all that in a second. Okay. Now, after all of this, so the structure that attaches to the bronchioles is now the alveolus, right? So now we're not in the airway anymore. What is the alveolus? It's a sac, right? So what happens in the alveoli? Gas exchange, right? So now here, if there's any problem with the alveoli, we're not looking at airway problem anymore, right? If you are doing a nursing diagnosis, what kind of nursing diagnosis is appropriate to use if there's a problem in the alveoli. Impaired gas exchange, right? Because now there could be an obstruction or a decrease in the flow of oxygen from the alveolus to the pulmonary capillaries that surround that, right? Or the flow of CO2 from the pulmonary capillaries to the alveolus, right? So as we move further into the more advanced respiratory conditions, we're going to look at those as well. We're going to look at respiratory acidosis, alkalosis, and how that happens, okay? All right. So so these are airway, and then that is the air sac. So let's start with things that could go wrong, and this is more for peds in the epiglottis area. Okay, anyway. So in the epiglottis, let's look at something that could happen that is a problem. So another concept to kind of look at is the concept of inflammation, right? So in the concept of inflammation, what are the things that happen? That way we know, like when we see an itis, we kind of already know what the things are that we're going to see, right? So we're going to put that here, kind of on the sidelines here, inflammation. So when there's an inflammation, let's put the different color here. So what's the concept of inflammation? What are the things that we see in it? True. Can you go back to the pathophysiology of that? So what is causing all of those symptoms? So when there's inflammatory mediators, right? Can you guys tell me some names of inflammatory mediators that you remember? What is it? Cytokines, yeah, those are like the intense ones. So those are killers. But before that, we have histamine, right? Histamine, bradykinin, right? Prostaglandin, that's an inflammatory mediator. And interleukin. Okay, if some of these, words kind of ring a bell, right? Mast cells. Okay. IgE, it's not an inflammatory mediator, but it's a antibody that is involved in inflammation, IgE, right? So when all of these inflammatory mediators are released, then what happens? So one of the first things that happen is vasodilation, okay? And I'm going through this because I want you to take this concept and apply it to any med-surg concept, topic, okay, that wherein there's an inflammation. So there's going to be vasodilation. So when there's vasodilation, what happens to the blood flow? It's going to be increased, right? So what if this is something that is kind of more superficial, it doesn't apply to the lungs, but if this is something superficial, what are you going to see that is a sign that there's increased blood flow? Redness, right? Okay, and because there's increased blood flow, how is that going to feel? Warm. Okay. So vasodilation is what causes the sign and symptom of redness and warmth in inflammation. Okay. What else is going to happen? There's going to be increased capillary permeability. What does that mean? Anybody know what that means? So what is capillary permeability? Right, the capillary walls, right? So what happens in the capillary? We know that's where there's exchange of oxygen, the cellular respiration, right? It's not respiratory, but it's cellular, in the tissues in the cells. So if there's increased capillary permeability, that means that the holes, if you will, of the walls of the capillary are bigger, right? And so the blood components that are supposed to be just inside the blood now is able to escape out into the area where there's an inflammation, right? What are the things that escape out? Your WBC, right? And if your WBC escapes, what do we see? If this is, let's say, a cut on the skin, what do we see as a sign that there's WBC that has escaped? Secretion, drainage, right? What if it's in the lung? What do we see that is a sign that the WBC has escaped? Same thing, secretion, sputum, mucus, right? So secretion, drainage, pus, if there's any bacteria, right? That is all a component of the WBC and immune system macrophages as well, right? What is the job of the macrophage? It engulfs whatever the antigen is, right? So then it causes all of this mucus and secretion, okay? The other thing that escapes because of capillary permeability increasing is albumin. What is albumin? Protein, very good. What is the job of albumin inside the blood vessel? Make sure you're signing in, Villa. Very good, right? It causes oncotic pressure, right? Basically, wherever the albumin is, it sucks fluid into it, right? So an albumin is supposed to be inside the blood vessel. So if the albumin escapes out of the blood vessel, wherever it goes, that's where the fluid is going to go, right? And so because it escapes, we'll say leak out, then what happens to the area where the albumin is at and fluid follows? Now you have edema, okay? Because edema is fluid in the interstitial space, right? Now in areas wherein there's nerve endings, that edematous area is gonna put pressure on nerve endings. And so then what other symptom of inflammation is the patient gonna have? Pain. So what are the symptoms of inflammation? Again, you know, we doesn't apply to all types of inflammation, but depending on which area we're talking about, but this is how your pain, your edema, your secretions, your redness and warm, this is how they happen. Okay, so this is inflammation. So we can apply that concept on wound, we can apply that concept on phlebitis, right, thrombophlebitis. We can also apply that concept in inflammation in the lungs, okay? So now that we know the concept of inflammation, let's go back to the areas of the lungs that could have some type of inflammation. So we were here in the epiglottis, and if there's, let's put the problem first, put that in purple. So epiglottitis, right? So epiglottitis, there's an itis, so we know that there's inflammation of the epiglottis, right? So if there's inflammation of the epiglottitis, then what is blocked? What is that? Airway, right? I can get these arrows too. Okay, we'll just put a text here. So there's inflammation, and that's going to cause blockage of the entire airway, right? Because it's on top of the entire airway. Okay, so now that there's blockage of the entire airway, how is the, no, let me back up. So there's inflammation of the airway, it causes blockage of the airway. So then what is being blocked? What is being blocked? Air, right? Blocks air, obviously blocking O2 from going into the respiratory system. Yeah. Now, if there's so much inflammation, it not only will block air, if the, what is the structure that's right next to the trachea? Esophagus. So if there's so much inflammation, do you think it will block the esophagus? Yeah. If too enlarged, also blocks esophagus. Now, the symptoms that we see in epiglottitis is going to stem from these two things, right? So if there's blockage of air, then is there going to be a lung sound? No, because there's no airflow, so there's no breath, so therefore there's no breath sound, right? Or it's going to be very diminished, okay? Because this patient is not getting any air, okay? So there will be, therefore, decreased breath sounds, decreased O2, and so if there's decreased O2, we call that hypoxia, right? If there's hypoxia, where could there, what is the first system that is affected? What's the first system? Let me rephrase that question. What is the first sign of hypoxia, especially in peds? Did I hear cyanosis? That is late. Cyanosis is late. What is early? That's a compensation. Huh? That's also a compensation. Who said that? Very good. So lack of oxygen to the brain, right? So that's one of the first things that we'll look at is there's going to be decreased CNS activity, right? So then in the child, how does that present? They're going to be restless. They're going to be irritable, right? There might even be some confusion, hallucination, okay? And then if it gets really bad, they would become lethargic, right? So all this is the first sign of hypoxia, okay? So then when we have these issues, this is what we look for, okay, in epiglottitis. So I'm going to highlight that red. That's one of the first things you look at. Naturally, vital signs, we already know because this is respiratory. I'm not going to put those because those are all the same. If there's lack of O2, the brain compensates. So your respiratory rate is going to increase. Your heart rate is going to increase. Your blood pressure is going to increase, right? That's natural. That's all part of it. And then if it gets really bad, then we know we're going to see the hypoxia through the pulse oximetry, right? And the SpO2 will be decreased. That's all classic signs. Okay. Now, the other issue with epiglottitis is because of the blockage of the esophagus. So when the esophagus is blocked, what is the patient not able to do? Swallow, okay? So then how do we know that the patient is not able to swallow? There's drooling, okay, and gurgling, okay? So this is another presentation. So we'll put that in red. That is another presentation of someone with epiglottitis. Okay, so in a child with epiglottitis, what do we look at? Lethargy, drooling, gurgling, because they can't swallow, their epiglottis is too enlarged, airway can't go in. Air can't go in, saliva can't be swallowed, okay? We'll talk about nursing interventions and other considerations later on, okay? What causes epiglottitis? Correct. Any idea which one? No? Third and fourth, come on. What causes epiglottitis? Bacterial, did you say bacterial? You said bacterial, bacterial. Bacterial, which one? Think, yeah.
Turn on.
Turn on. Drink some more coffee. Huh? No. Huh? 3 letters. No, not RSV. That's a virus, guys. That's not a bacteria. Starts with an H. No, not HPV. No, that's nope. Oh Lord. Third and fourth. HIV. Haemophilus influenza B. Right? Do you remember now? So Haemophilus influenza B, which is a bacteria that the patient should not even be experiencing because we have vaccinations for them, right? This is part of that primary series that is given at 2, 4, and 6 months. But because we have a lot of patients now who don't believe in the vaccinations, and if they don't get that Hib, their child could still get this bacterial infection. And this is why there's a vaccine for it, because it's deadly. So epiglottitis is a medical emergency, right? This is a very deadly situation. If that airway closes, what are you going to do? You're going to have to put a trach on this patient. There's no other way, right? Because how are they going to get the air, right? You can't push a tube through the epiglottis. Is swollen. So there's no other way but a trach. Okay. So yeah. Okay. So that's epiglottitis. So peds, that's mainly for you guys, or I guess for everybody who forgot. So epiglottis, epiglottitis. Okay. Now, in the area of there's another condition that involves the trachea and maybe like some part of the bronchi. Another part that I didn't mention here is the larynx. Where's your larynx at? Where's your larynx at? So trachea, so remember your laryngo pharynx, right? So your pharynx, so you have your nasopharynx, oropharynx, laryngopharynx, larynx, trachea, bronchus, right and left bronchi, right? So it's kind of up there, yeah? So that is what is the function of your larynx? The voice box, right? So we're gonna put a larynx kind of up here, right above the trachea. Okay, so the point I'm making is there's another condition that is common in the pediatric population that affects the larynx, the trachea, and the bronchi. Third and fourth, what is it? I am so glad you guys are here. What is the condition in pediatrics commonly that affects the larynx, the trachea, and the bronchi? Anybody? Somebody had an idea? I heard an O. No? Starts with a C. Croup. So croup, what is the technical name of croup? Long name. Laryngo, tracheal, bronchitis. Laryngotracheal bronchitis. So because it affects all of these areas, right? The larynx, the trachea, and the bronchi, we have different presentations, right? So because there's laryngitis, right? Because it involves the larynx, what is a symptom of that? When you have laryngitis, what's wrong with you? How do you present? Hoarse, right? You have a hoarse voice, okay? So the patient is gonna have a hoarse voice. And they're gonna have tracheitis. So meaning there's gonna be a constriction of the trachea, correct? Just because there's inflammation, right? So there's edema, there's constriction. So then let me rephrase that. What happens, what will you hear when air tries to flow through that area of your airway that is narrow? Stridor. So then what is another term for stridor? What is another term for stridor? How does it sound? High pitched. What else? Whistling. Is it typically inspiratory or expiratory? Inspiratory, right? Is it loud or soft? Loud. So it's loud, inspiratory, wheeze, right? So why is it loud? Why is it loud? What is the principle behind that? Because the airway is larger, right? Your upper airway is larger than your lower airways, correct? So that's a principle of auscultation. The larger the airway, the louder the sound that you're going to hear. Now, this is so large, right? Your trachea is so large that the sound is amplified even without a stethoscope, right? You can hear a stridor even without putting a stethoscope on the patient's chest. You could just be standing right there and you could hear it, right? Now, why is it inspiratory? Because the problem is up here in the upper airway. So then as soon as air hits that area where the problem is, you hear it right away. So you hear it on inspiration. As opposed to, question? Correct? Correct? Correct, which is what it's high pitch. So it's high pitch because it's narrow, but because it's also still large, that's why it's loud. Now, if you think about that and you apply it to a small airway, right? We have the bronchioles over here, right? The bronchioles are small. And you take that same principle, right? So it's a small airway. So is the sound going to be loud or kind of soft? Are you going to need a stethoscope or no? You're going to need a stethoscope. Okay. Is it going to be high pitch or low pitch? High pitch because it's very narrow, right? When we go to the bronchioles, okay? So if there's narrowing of the bronchioles, it's going to be high pitch. But however, it's at the end of the airway. It's not at the beginning. So when are you likely to hear the sound? Are you going to hear it when the patient breathes in? Or are you going to hear it when the patient breathes out? Expiration. Expiration. Because you can still hear it inspiratory, right? But it's kind of at the end of the inspiration because air has to flow to that part first, right? But what happens is when those alveoli squeeze the air out, the bronchioles are right there, right? It squeezes the air out, air flows out, you hear it right away. That's why you hear it expiratory. Okay. So what's the point in saying that? The characteristic of the sound that you hear will give you a clue as to where the problem is and what is causing the problem. That's why it's very important that you recognize all of the sounds and what they might be applicable to as far as conditions. Okay, so far you understand where I'm at so far, right? So laryngo, the larynx, the laryngitis is causing the hoarse voice. The tracheitis is causing the stridor, right? Now, while we're in that topic, what about if there's anaphylaxis? What kind of sound is that going to make? Wheezing, What else? Is it going to be loud or soft? It's still going to be loud because it's still in the same anatomy. It's still going to be a stridor, right? A different disease process. Anaphylaxis, there's swelling, there's inflammation of what? The upper airway. Is the upper airway at the beginning of the airway or the end of the airway? Is it the beginning? So are you going to hear it inspiratory or expiratory? Inspiratory. Is it going to be high pitch or low pitch? It's narrow. It's high pitch. Is it going to be loud or soft? It's big. It's loud. Stridor. So when do we hear a stridor? We hear a stridor in anaphylaxis, a partial foreign body obstruction, laryngospasm, or croup. What do they all have in common? They're happening here. And there's either constriction or swelling that's causing narrowing of the airway. Okay? Does that make sense? Okay. So then the other part of this is we have bronchitis. So when we have bronchitis, is there usually secretion with bronchitis? Remember, there's the itis, right? So is there secretion in bronchitis? So what is your lungs going to do when there's secretion in the bronchi? You're going to cough it up, right? Let's see if I can get this too. Now, so we know where there's going to be a cough, okay? Now, we said that there's also laryngitis, yes? So there's also laryngitis and there's bronchitis. So what type of cough, how would this cough differ from any other type of cough? It's going to be a barking, seal-like cough, right? What does that mean, seal-like? It sounds like a seal, right? Why does it sound like a seal? Because of the laryngitis. So when they're coughing, it sounds a little bit different from a usual cough because they have that laryngitis. Like I have, I have like a little laryngitis. So if, not gonna sound like a seal, but if I were to cough with a croup, I'll be like, right? I'm supposed to, right? There's a little bit of like raspiness to it, okay? So these are all characteristic word association, test keywords for croup, okay? Barking cough, stridor, hoarse voice, laryngotracheal bronchitis. What is the cause? What is the etiology? What causes it? Third and fourth, what causes croup? Huh? RSV? Common virus. I would not, so categorically, RSV is a virus, right? Mm-hmm. So then you could say RSV. However, for test taking purposes, I would not want you to associate RSV with croup. I would ask you to associate it with another condition later on. Okay. So, yeah, usually common virus. Now, because it's a common virus, if it's mild, do we do much with it? Do we treat the patients with a lot of treatments? Not really. You treat the symptoms, right? So it could be just walking at night, just get some humid, cool air, like, walk the beach, right? If it's more severe, how do we know that the group is more severe though? What happens to the signs and symptoms that we see here? They go away. The stridor is decreased. That's not a good thing because that means that the airway is closing up. And then how do we know that that's a bad thing? Well, we're going to go back to the signs of hypoxia here, right? And we're going to say that these are the signs that we're going to be watching out for. So children or adults, when there's hypoxia, these are the initial signs that we would look for. Is there restlessness, irritability, confusion, and lethargy? Okay, I give up. Let's see here. Okay, so you guys are good. See, these are mainly, again, peds patients. So epiglottitis, croup, laryngotracheal bronchitis. Now, since we're on bronchitis, let's continue with that because there's generally two kinds of bronchitis. So we're gonna put two bronchitis here, two arrows. And again, they can happen to the, they can happen to the main bronchus, the secondary bronchi, tertiary bronchi, okay? Those are all still bronchitis. But we will put here the two main bronchitis that we're concerned about. One is acute bronchitis. And when we say acute, I mentioned acute yesterday. Do you guys remember the 3 S's of an acute condition that I talked about? Short, severe, and sudden, okay? Short, severe, and sudden. So what causes an acute bronchitis? What causes an acute bronchitis? Let's put it over here with arrow here. Jose? Say again? Not for acute, not for acute. So an acute bronchitis is infectious, right? So this is an infection. And what kind of infection? What causes that infection? It could be threefold. It could be what's most common? Virus, right? What's the next most common? Bacterial. What's rare? What do you think? Fungal, yes, absolutely. Yeah, fungal. Okay, so who gets fungal? Not a lot of people. Usually your patients who are immunosuppressed. Okay, who are immunosuppressed? HIV patients and cancer patients who are taking chemotherapy drugs. Okay, who else? People with autoimmune disease who are on steroids, long-term steroids and long-term immunosuppressants. Okay, people who just underwent organ transplant. Why? Because they're taking an immunosuppressant so that they don't get a rejection. Okay, so those are the people at risk for a fungal bronchitis. Other than that, common population, not as common. Okay, so usually virus, possibly bacterial. How do we know the difference between a viral bronchitis and a bacterial bronchitis? The sputum, what about it? Correct? Exactly, exactly. Because that bacteria interacts with your immune system, right? And so when the bacteria breaks, it causes like these different colors depending on what the bacteria is, right? So it could be green or yellow, okay? So secretion, not just in the morning, okay? I don't count morning secretion because in the morning when you're just waking up, everything's concentrated, like your urine's concentrated, your secretion's concentrated, don't count that, okay? So you wanna ask your patient, when you cough throughout the day, what color is your sputum? Okay, and if it's kind of white or clear, okay, that could be viral, that could be allergic. Okay, if it's green or yellow, then that's most likely bacterial. If they say, oh, kind of brown, what do you think that is? Huh? Old blood. So there could have been some bleeding in there from the inflammation. Remember, there's an inflammation, right? So, so there's an inflammation in the bronchi that is acute. So again, it's either virus, bacterial, fungal. We're going to talk about treatment later on. But when there's inflammation in this airway, what sound is that going to make? Bronchi. I heard wheeze. Is wheeze correct or no? It can be, yeah. What kind of wheeze? So I think I failed to mention that in the airway, the whole airway has a last name, if you will, of sound, and that's wheeze. So the whole airway can cause a wheezing sound. But the characteristic of the wheeze will vary depending again on what I talked about, which is the size of the airway, the diameter of the opening of the airway, okay, and the location of the airway, okay? So we talked about stridor earlier, which is typically an inspiratory wheeze, right? That is loud, that is high pitched, okay? Bronchi is sometimes known as a sonorous wheeze. So what does that mean? It sounds like snoring. Okay, so it sounds like snoring. Why? Because there's secretion that's attached to the wall of the bronchi. Okay, now it could be partially constricted, but it's still a larger airway. So I kind of changed some of the things around. Not that it's any neater, but as you know, I like to color code. We're going to keep the diagnoses as this purple one here. So far, just as a review from before we got interrupted. So we talked about epiglottitis, which affects the epiglottis. This is the pathology of that. The blocking of the esophagus causes the drooling and gurgling. The blockage of the whole entire airway will cause the hypoxia, and these are the signs of hypoxia. Starting in the pediatric population, it starts with the restlessness, irritability, confusion. You notice that I didn't include the classic signs of respiratory issues, which is the increased respiratory rate, increased heart rate, increased blood pressure, decreased O2 sat, right? Because that's a given. But what I want to indicate on here are like the more specific ones for each kind of condition. So we talked about laryngotracheal bronchitis, God bless you, wherein we break down this word into three. And again, this is commonly known as croup. In laryngotracheal bronchitis, we have the laryngitis, which causes the hoarse voice. We have the tracheitis, which causes the stridor, which is a loud, typically inspiratory wheeze. It could be biphasic. Biphasic means in and out if it's really bad. And then we also have bronchitis as part of that. And again, because there's bronchitis, there's secretions in the bronchi, your cilia is going to want to excrete that out. And so the patient's going to have a cough. But because of the laryngitis, the cough is going to be characterized as a barking, seal-like cough, right? And then we move down to still in the upper airway in the bronchi. And when we're in the bronchi, the sound that it makes is a bronchi. Bronchi in the bronchi, right? Bronchi doesn't happen in the alveoli. It only happens in the bronchi. And there's two kinds of bronchitis that we're going to zone in on, which is your acute bronchitis and the chronic bronchitis. As we mentioned, acute bronchitis is usually infectious. And what infection? Typically virus is the most common, followed by bacterial, and then least common is fungal. And as far as presentation, it doesn't really make a big difference as far as the lung sound. It's still going to be a bronchi, but treatment-wise is why I want to distinguish the two. Okay, because when we go to the interventions will differ from acute versus a chronic bronchitis. Okay, So in chronic bronchitis, this is not infectious, right? Chronic bronchitis is inflammatory. Okay. We already talked about inflammatory. We already talked about inflammation, right? So what did we say happens when there's an inflammation? There's going to be edema, there's going to be secretion, right? But one thing that the patient is not going to have because it's not infectious are signs of infection, which is, and let me add that over here. When someone has infection, they have a fever, right? If someone has an inflammation that is not caused by an infection, they're not going to have a fever. Okay, there's going to be local warm, but there's not going to be a systemic fever, right? Because there's no pathogen that the hypothalamus has to release pyrogenes for. And pyrogenes is what causes the increase in the temperature. And pyrogenes are released if there's a pathogen. Okay, so in inflammation, there's no pyrogenes. Okay, so inflammatory, when we say inflammatory, typically this is caused by what? Not autoimmune. So what were the inflammatory mediators that I talked about earlier? Histamine, I mentioned IgE, right? Mast cells. In this situation, not so much prostaglandin, maybe a little bit, but not so much. And then interleukins, yes. Bradykinin, we won't add those. Leukotriene, that's the one that I wanted to say, leukotriene. So these inflammatory mediators causes the chronic bronchitis, right? So chronic bronchitis is inflammatory. Acute bronchitis is infectious. Is the sound going to differ? Is the lung sound going to differ between acute and chronic bronchitis? No, because it's happening to the same anatomical structure, right? Is there inflammation in both? Yes. The difference is there's no infection on this one, right? So when there's an infection, there also is an inflammation, right? But again, in an inflammatory without the infection, there's no fever. Okay. Now, if we're looking at blood tests, how is that going to differ? Correct. So let's add that to here. And let's actually classify that based on the pathogen. Okay, so that we're kind of putting in a little bit of CBC on here as we're going. So if it's, let's start with bacterial. If it's bacterial, what do we see in the CBC that will be increased? So increase, let's be specific. Let's do a differential. Neutrophils, very good. So if it's bacterial, it's going to be an increased neutrophils. We'll put that in red because that is a sign. Now, what about if it's viral? We're doing a differential. What will increase if it's viral? Increased. And this is initially, okay? Not in a very severe viral condition, because in a very severe viral condition, this is going to deplete lymphocytes. Because if you recall, well, maybe you don't know, the lymphocytes fight viral infection. Okay, your T lymphocytes, that's your job, right? In cancer. So third semester, when you go to hematology and immunology, remember that. Okay, your T lymphocytes kill viral and cancerous cells. Okay, so if there's a viral infection, your neutrophils is going to be normal or maybe even slightly low, but your lymphocytes might be increased. If it's a bacterial infection, your neutrophils will be increased, not your lymphocytes, okay? This is why we do a diff. This is why we do a differential, because if we don't do a differential, we're just looking at WBCs as a whole. We don't really know what's going on and what's causing it, okay? Now, if it's fungal, if it's a really bad fungal infection, what could get increased? Eosinophils. Now, along those lines, when else are eosinophils increased? What other condition? Allergies. So this inflammatory issue here, right, that we talked about will also cause an increase in your eosinophils. So this chronic bronchitis patients, when you see their blood test, your CBC, they might have a slightly elevated eosinophils, and that's perfectly okay. That's normal. That tells you, yes, this is inflammatory, okay? Sinus infection, not sinus infection, but allergic sinusitis, you'll have an increased eosinophils, okay? Because that's when they're active, okay? So we're gonna move on to other conditions, and we're still in the bronchi. So another condition that could cause problems in the bronchi is something that we could kind of almost classify as part of the chronic bronchitis, which is bronchitis in cystic fibrosis. Okay, and so this is not really a bronchitis if you really think about it. But it's just that in cystic fibrosis, there's a lot of secretions that get stuck, not just in the bronchi. Right now, we're just talking about the bronchi, but it's not just in the bronchi, but it's really in the whole respiratory system. But in the bronchi, if there's cystic fibrosis and there's secretion in the bronchi, then what sound are we going to hear? What sound are we going to hear if there's a problem in the bronchi? Bronchi, right? Bronchi in the bronchi. Does it matter what the cause is? No. It's still going to be bronchi in the bronchi. You follow? Okay. This is going to be pretty severe. Okay. So we'll still hear that bronchi sound. And then as we go down, the sound will change. The characteristic of the sound will change because the airway is going to get narrower and narrower. So we'll talk more about that later on. Okay. So if there's cystic fibrosis, meaning there's secretions in the main bronchi or in the primary, secondary bronchi, we're going to hear a bronchi. So then how does this progress? So because of so much secretion in the bronchi, and this is chronic, right? This is lifetime, right? They might have exacerbations, they might have like remissions, but for the most part, there's always going to be secretion in the airway, right? Because of so much secretion, so this could lead to bronchiectasis. Okay, what is bronchiectasis? Collapse of the bronchi, right? What sound are you going to hear? None? The patient's not breathing? Diminished? So what do you think happens when there's collapse? And I see where you're getting that from. So when I say collapse in here, I don't mean it folds in. It means that it loses its elasticity. So then it kind of looks like that. Okay, so the bronchi becomes just kind of more floppy. And so when it becomes floppy like that, then what's left inside? A lot of secretions, right? So the secretions now can't get out. Okay, now eventually, yeah, if the secretion is so much here, what do you think is going to happen? it can get stuck together, right? Then it closes the airway. That's a problem, right? But before that happens, if there's still like a little bit of space in there, so what sound are we going to hear? Where's the problem? In the bronchi. What's the sound? Bronchi. Is it going to change? No, because it's still in the bronchi. It doesn't matter what the condition is. Are you guys beginning to get it? I've asked it like a million times. It's still going to be a bronchi. Okay. So let's move on to, and by the way, if this collapses, they just take out that part. Okay, they're going to have a bronchiectomy. They're going to remove, or a lobectomy, remove that part of the lung because it's all shut already. There's nothing that they can do about that. Okay, or this patient eventually gets a lung transplant if that's possible for them. Okay. Okay, so moving down a little bit further in the airway into the bronchioles. So in the bronchioles and in the tertiary bronchi, if there's an inflammation there, the sound will be a little bit different. Let's first look at the problems. Okay. Now, yeah, let me go back here first, and let's say if there is inflammation of the bronchioles, what is the diagnosis? What is it called if there's inflammation of the bronchioles? Bronchiolitis, right? Because it's inflammation of the bronchioles. Okay. In pediatrics, what is a common cause of bronchiolitis? What is a common cause of bronchiolitis? Third and there you go. Now you say RSV. So classically speaking, RSV in children causes bronchiolitis. And I say classically because since COVID, everybody's gotten RSV. Even adults has gotten RSV, right? And RSV, because it's a virus, had also caused bronchitis, had also caused pneumonia, right? God bless you. Okay. But if we're sticking to like classic textbook, information, bronchiolitis is usually caused by RSV. Now, who's at risk? Let's put that here. In the pediatric population, who's at risk? What do they have in their history? Preemie. So they're preemie, and age again is so infant to how old? 2 to 4, even up to 4 years old, but commonly, again, classically 2. Okay. So what is that telling us? If a child presents with, we haven't talked about the lung sound yet, but we will in a second here. But I'll just put that here. This is the population in which this is most common. So how is this patient going to present? Let's look at lung sound. So it's happening to the bronchioles, right? If there's inflammation in the bronchioles, is it going to get narrower? Okay. Where are the bronchioles? Is it in the upper airway? Is it in the lower airway? In the lower airway. So what family of sound does the airway make? What is the last name that I said? Wheezing. So we already know this is going to be a wheeze. Now we just need to categorize what kind of wheeze, right? Is it going to be inspiratory or expiratory? It's going to be expiratory. Is it going to be high pitch or low pitch? It's very narrow. It's very tiny. High pitch. So where do we hear expiratory high pitched wheeze? In the small narrow airways. Okay, again, that's an airway sound. Okay, so expiratory. So remember, RSV is a virus. The disease is bronchiolitis, right? But I mentioned to you that because it's a virus, it doesn't mean that it only causes bronchiolitis. You could have RSV bronchitis, you could have RSV pneumonia, but the sound that something makes is dependent upon not the pathogen, but it's dependent on what? The anatomical structure where it's at. Okay, so you will hear that later. You will be correct at some point. Okay. But you know, I kind of want to put these here to kind of for like word association, again, kind of test taking strategy purposes. So you know, like for the classic presentation of stuff, you know what the causes are. Okay. In real life, you inhale a pathogen, it could cause you know, havoc in any part of the lung structure. Okay. And we'll get to that in a minute. So bronchiolitis, is this infectious or is this inflammatory? Infectious, right? Because it's a virus, right? So this is infectious. So is this patient going to have a fever? Yeah, because it's infectious, right? So we'll add that again. I think we had that in the bronchitis part, but we'll just add that again here, in addition to the other symptoms. And of course, there's going to be, I'm not even going to put cough because, you know, we already talked about if there's secretions in there anywhere, your cilia is going to want to excrete that out, right? So there's going to be cough and the airway. Any part of the airway or the alveoli where there's secretions, there's going to be cough because your lungs going to want to get that out. So what are the classic signs and symptoms for all of the lung diseases? We're going to have tachycardia, tachypnea, high blood pressure, low SpO2, and cough, right? Because that's in the lungs. So now, let's talk about another condition that is not, that is not infectious, but is inflammatory. So there's an inflammation in the bronchioles that is not caused by an infection. What is it? Asthma. So is there fever in asthma? No, because it's not infectious, right? Is there cough in asthma? Yeah, absolutely, because there's secretions, there's an inflammation, so there's secretions in the airway, right? What kind of sound are we going to hear? What kind of wheezing? So it's going to be the same expiratory high-pitched wheeze because where is it happening? In the bronchioles. Is that making sense? Okay. The sound doesn't change because of the disease, the diagnosis. It changes because of the anatomy. Okay. If it's the same anatomy, regardless of the diagnosis, the sound is the same. Okay. But what's different about asthma? We said that this is not infectious, this is inflammatory. Do you recall us talking about something inflammatory earlier? What condition was that? Very good, chronic bronchitis. So let's go back to the inflammatory over here. So what caused the inflammatory condition here? Histamine. Yeah. And let me just re-clarify. I'm glad I went back. So what triggers the histamine and the IgE and the mast cells to cause an inflammation here? Allergen, right? Allergen causes an allergy. Okay. When we say allergen, can you give me an example of an allergen? Pollen, dust, dander. What else? Smoke. Smoke inhalation. Okay. So in the United States, chronic bronchitis is classified, well, not in the United States, but chronic bronchitis in general is classified as a what type of condition? It's classified under what type of condition? COPD, very good. Okay, so chronic bronchitis is a COPD. What does COPD stand for? Chronic obstructive pulmonary disease. Okay, let's actually write that out. Chronic. And when we say chronic, how long is chronic? I mean, onset-wise. Very good. More than 3 to 6 months. 3 months is sufficient to say something is chronic. Okay. So chronic obstructive pulmonary disease. I mentioned this because we are going to come back to this in a minute. Let me just put that in purple. Okay, so that's classified as that, COPD. In the urban setting, what causes COPD the most? This smoke inhalation here, right? Smoke inhalation in the sense of cigarettes or pollution in the cities, right? Someone can get chronic bronchitis, COPD, from living in only those apartments by the freeway. I don't know who would live there, but you know, they know who they are. But they're just inhaling all of those pollution from the freeway, right? Chronic bronchitis. In the rural area, what causes COPD? It's still smoke inhalation, but from what? From cooking. Because if they're in a rural area and they don't have electricity or gas, they're going to use wood to cook, right? So those people will also get COPD, but not from smoking cigarettes or tobacco, but it's from cooking every day. Okay. Now there is, we'll get to the kind of genetic part that causes the other COPD later on. Okay. So we're in inflammatory. And so what I brought that up to say that all of this inflammation here is the same causes of an asthma. Okay. So the allergens that we talked about, the smoke inhalation, that the activation of the histamine is exactly the same. Okay. What is an additional factor? Genetics. Okay, so who gets asthma? Someone whose parents either had like chronic allergic sinusitis or eczema. These are all called atopic disease. Okay, they're all caused by allergies. Okay, by allergens. And so, or if you had like asthma as a parent, your child can get eczema. Or they could have like, you know, chronic allergic sinusitis because they're all in the allergy family. Okay. So they're not always going to inherit the same condition, but it's a related condition that they're probably going to inherit. Okay. So in asthma, because there's an inflammation, we're going to add the other thing that happens. So we already know about if you go back to, I moved the inflammation, by the way, there it is. So we talked about redness, warmth. Well, we're not going to see that because it's in the lung, but we know there's going to be secretions, right? There's going to be edema. Not so much the pain part, but we know there's going to be secretion. But the other component of asthma that is different is that because of this inflammation, it also triggers the sympathetic nervous system. Okay. And sorry, ANS, autonomic nervous system, which is similar. It's just involving the other part as well. So when it triggers the autonomic nervous system, the symptom, the sign really that's going to happen is there's going to be bronchial constriction. Why? Because of the inflammatory mediators. Okay, So that is an extra thing that happens in asthma that doesn't always happen in bronchiolitis. Okay. So technically speaking, there is not any bronchial constriction. And when I say bronchial constriction, I mean spasm. Okay, spasm. Different from constriction that is just getting narrow because of the inflammation. Okay, I'm saying spasm of the bronchioles. Okay, that's different. Which is why treatment-wise later on, as we talk about that, there's a different approach to bronchiolitis versus asthma. Okay, now there's also a different kind of asthma. So there's like a subtype of asthma that is called either stress-induced, stress or exercise-induced asthma. Okay, how is this different from regular asthma? There is no inflammation here because it's triggered by the sympathetic nervous system, the autonomic nervous system. And so these patients will not have any secretions, but will have the bronchial constriction only. Okay. And so these patients, they will only have what sound? Expiratory high-pitched wheeze. They will only have the expiratory high-pitched wheeze when they're stressed out, when they're panicking, when they're doing a lap, when they're in PE. Okay, as they're doing that, their autonomic nervous system is getting hyped up. It causes the bronchioles to constrict, to spasm, and all of a sudden they're wheezing. Now you have them relax, you stop the activity, you stop the stressor, and then all of a sudden the wheezing goes away. They go to the doctor, they're totally fine, no wheezing, right? Because it's induced by the ANS, okay? So let me actually correct that. So treatment-wise, that's gonna be a little bit different. Similar, but it's not as involved as if there was an inflammation. Okay, there will be no anti-inflammatory needed because there's no inflammation. It's just constriction. So you only address that part. Yeah, because remember how this links, right? If it's inflammatory, there's also bronchial constriction. So it could be that they have the inflammatory asthma that is also triggered by activity, because it also activates the ANS. So now let's go to the alveoli. So far, just to kind of summarize where we're at, let me see if I missed any PEDS issues here. We talked about epiglottitis, bronchitis, cystic fibrosis, that's PEDS, COPD, that's adult, bronchiectasis. But by the way, you might hear people talk about the chronic bronchitis patients, the COPD, as blue bloaters. Have you ever heard of that? Blue bloaters. So because their main issue, we'll put that here in a parentheses, their main issue is getting O2 in, as opposed to the other one, which we'll talk about next, that where their main issue is getting CO2 out. Okay. So these people are called blue bloaters. Why are they called blue bloaters? Because they're blue. Okay, that's a sign. Okay, of chronic bronchitis. All right. So in the alveoli, let's talk about something acute first. I mentioned to you that if there's a problem in the alveoli, there's going to be, let's draw an alveoli here, actually. Alveoli, and then we're going to draw a pulmonary, a capillary kind of surrounding that alveoli, right? All alveoli are surrounded by pulmonary capillaries, right? And that's how O2 goes in, CO2 goes out, right? And so let's talk about the different issues that can happen here, beginning from something that is acute. So if there's an acute condition, and again, that's infectious, right? And that infection is called what? Pneumonia. Very good. So pneumonia happens in the alveoli. Okay. And pneumonia, the acute pneumonia, which I mean, pneumonia is acute because it's infectious, will be caused by the same pathogens that we talked about here. These same pathogens. Okay. So then treatment will be the same, right? Okay, so now what happens in pneumonia? We talked about inflammation, right? There's going to be an infection that causes an inflammation. So when there's an inflammation, there's going to be mucus, correct? So when there's mucus, and I'm going to draw a different, so when there's mucus in there, an infection, and it's inflammatory, so it's kind of red. So when there's secretions in there, what sound is it going to make as the air molecules try to get through the secretion here? What sound? Crackles, very good. Okay, so in the alveoli, if there's secretions in there, is going to cause crackles. Now, what kind of crackles? Fine or coarse? Fine. Why fine? Yeah, it sounds like Rice Krispies for sure. When you say fine, it's small sounds, right? Like fine, finer, right? Coarser, finer, coarser. Bigger, coarse is big, fine is small, right? So why is it fine? Because it's secretions, it's thick, right? So it's harder for the air molecules to be able to go through the thick secretion. Okay, so there's gonna be some bubbling sound, but it's more like tiny little Velcro. Okay, or like you put Rice Krispie on cereal, that kind of sound. Okay. So however, you guys want to associate that with whatever sound, like some people will say, like you get your hair and you rub it together, that sounds like fine crackles. Okay. Or I actually hear that sound like, like how, you're laying on your pillow and you have hair like this, try and do that, like, and then move your head a little bit, you will hear fine crackles. Okay. That's how fine crackles sound. Okay. So pneumonia will cause fine crackles, right? And we know that it's infectious. Let's stay here for a little bit more and let's talk about the signs and symptoms that we are going to see because of this secretion in the alveoli. So the first thing that will happen, will it be, let me ask you that question, will it be hypoxia or hypercapnia in pneumonia? What do you think will happen first? Hypoxia or hypercapnia? Will there be decreased oxygen first, or will there be increased CO2 in the blood? Hypoxia. Why? Because oxygen is water soluble. So, sorry, CO2 is water soluble. So it's harder for oxygen to go through than for CO2 to get out initially, okay? So there's gonna be hypoxia, and we've kind of talked about the signs of hypoxia earlier already, right? Where we're gonna have the restlessness, right? And then, actually just for the sake of listing it down here, we'll go ahead and put that. In the CNS, we're gonna see restlessness, lethargy, right? And then in the cardio, we're going to see increased heart rate, right? We mentioned that earlier. Obviously, to compensate, we're going to have increased respiration in the respiratory. And initially, we're going to have, that's why it's hypoxia, we're going to have decreased SpO2, right? What do we consider as hypoxia in a normal person? Less than 90, 92, right? Like what's ideal? We want it like 90, 94 to 100, right? So what, you know, when it gets kind of less than 92, we're like, okay, we probably need some oxygen now, right? And then as this gets worse, well, actually, I'll keep it there for now. We'll keep it there. Cardio, increased heart rate and blood pressure, right? And then there might be some weakness, right? Musculoskeletal, maybe some generalized, some fatigue, right? It's harder for them to get some rest. Maybe some generalized weakness, you know, a little bit of mild malaise, right? What is malaise? Weakness, right? Different from fatigue, right? Fatigue is tiredness, malaise is weakness, okay? But they both affect your musculoskeletal system, right? So these are the common systems that are going to be affected. Now, if we don't treat this pneumonia right away, especially if this is bacterial or if it's COVID, right? Then the pneumonia can get worse, right? And so this can become, anybody have any idea what it becomes when it gets worse? Acute respiratory distress syndrome. Okay, so now we're getting into more advanced. This is fourth semester stuff now that we're talking about. Okay, so it becomes ARDS. Now, how is this different if it's ARDS? So if we draw this alveolus again, and we have, I'm just gonna put this black because I'm gonna illustrate something else in red. So we knew that we had a pathogen, right? So the pathogen here caused inflammation, secretion inside the alveoli, right? It also is going to also cause inflammation of the alveolar wall. Now, because there's inflammation of the alveolar wall, then it's harder for not only O2 to get in, right? But also now what? CO2 can get out. Okay. So now we're going to have a little bit more of the signs and symptoms. Okay. Here in pneumonia, and of course, if this is, you know, if this is infectious, so we already know we're going to have fever there as well, right? We already know we're going to have problems with our CBC, right? As we indicated earlier. So what's different with ARDS? Well, with ARDS, there's a more effects of the inflammation. So then not only are we going to have these, now our ABG is going to get affected, right? So what's the first thing that we look at in the ABG? True. So let me clarify myself. So there's really two things that we'll look at in ABGs. One is the pH, CO2, and the bicarb, right? That's all part of the ABGs. But we also look at the PaO2, okay? So the pH, let's start with the PaO2 because I mentioned earlier that hypoxia happens first, right? So now, not only is the SpO2 going to get decreased, now the PO2, the partial arterial oxygen, is going to get decreased. What is the normal value here? 80 to 100, okay? So when we start looking at hypoxia, it's going to be either mild, moderate, or severe hypoxia. Okay. When we say mild hypoxia, where this is less than 80 PaO2. When we say it's moderate hypoxia, this is less than 60 PaO2. When we say severe hypoxia, now we're at 40 PaO2, really bad. Okay. So this is separate. This is just oxygenation, right? And then at the same token, I mentioned to you that now CO2 is also not going to be able to get out, right? So then let's look at first the normal, so this is PaCO2, TCO2. What is the normal CO2? 35 to 45 mmHg, okay? Now, what do we associate with CO2? This is an acid, okay? So therefore, the higher the CO2, hey, Charles, the more acidic the patient's blood will become, right? The higher the CO2, the more acidic the patient's blood will become. So in this case, where the CO2 is not able to come out, what value are we expecting? High or low? High, so greater than 45, right? Which equals an acidosis, correct? Now, how do we truly know that there's an acidosis? We're going to measure the pH, right? And normal pH is 7.35 to 7.45. Let me tell you a little bit on the side note here about pH. pH stands for what? Potential, very good. Who said that? Very nice. Potential hydrogen. Okay. Now, potential hydrogen is not the same as actual hydrogen, is it? So actual hydrogen and potential hydrogen are opposite. Okay. So potential hydrogen and hydrogen ion are opposite. What causes acidity is not the pH, it's the H. But what we measure is the H. Okay, so the hydrogen ion is what causes acidosis. Okay, so this is an acid. Hydrogen ion is an acid. Okay, bear with me for a minute. I want you to really understand this. Okay, but what we're measuring is the potential hydrogen. So these two, we can kind of think of them as being inversely proportional. What does that mean? If the hydrogen ion increases, then what happens to the pH? It decreases. Okay. So therefore, if the pH is low, what does that mean? There's an acidosis going on, right? So if pH is low, that means the H is high. So there's an acidosis. If pH is high, that means H is low, there is an alkalosis. Okay. This is more like, the metabolic situation, but since we're talking about acidosis and alkalosis, we'll go ahead and include that on there. Okay. Why do I say all that? Because when we're looking at our pH here, if there's an acidosis, what happens to the value? It goes down, right? So this will be less than 7.35 in an acidotic state. To compensate, HCO3 normal is how much? 22 to 26. Some textbook will say 28. Okay. What do we associate with bicarb? This is a base or alk. Okay. Now, in a respiratory situation, this may be either low or, sorry, this may be either high or normal. Okay, depending on the compensation. Okay, but right now we're not even going to emphasize that because we're talking about something respiratory. Okay. So again, to go back. So we started with pneumonia. Pneumonia got worse. Pneumonia became ARDS, right? How do we know the difference? ARDS affects the ABGs. Pneumonia, not necessarily, but pneumonia affects your vital signs, right? You still have your fight or flight. So you're tachy, you're tachypnic, you're hypoxic based on the SpO2, right? ARDS, it's a little bit more involved, okay? When we get to this part where we're at severe hypoxia here, okay, now we're advancing this to the next condition that is even worse than ARDS, which is acute respiratory failure. So once we have a patient in acute respiratory failure, right? Now the respiratory system is failing. So then how are we going to differentiate the sign and symptom of a failure versus here ARDS and pneumonia? What's different? What happens to the respiration? It's going to be low. What happens to the heart rate? Is going to be low. Okay. What happens to the patient's ALOC? Gone. Not just lethargy, stupor or coma. Okay. So this patient's not going to be breathing on their own. Okay. This is the time that they get intubated and ventilated in acute respiratory failure. Question? Okay. Now, if they don't get intubated, I mean, this is, pretty easy to determine, right? What's going to happen next, right? So if they don't get intubated, this ARF leads to respiratory arrest. You did. No more breathing. So I want you to look at this progression here. From pneumonia to ARDS to ARF to respiratory arrest. In your elderly population, 65 and over, in your cystic fibrosis population, in your pediatric population, this can happen in a day. Okay, this can happen very, very rapidly. And in the pediatric population, they don't die of cardiac arrest. They get a respiratory arrest that leads to a cardiac arrest. That's how they die. Same, and again, same with your cystic fibrosis population. They don't die of pancreatitis or, any issues in the GI system. They die of a respiratory issue if you don't become really aggressive with treatment of this. Okay. Any questions so far? I'm gonna kind of zoom out, just gonna look at our whole map here. I know that's really small, but I just want to take a look and see if there's anything that I have missed so far. I have missed some that doesn't involve the inside of the lung. It involves outside of the lung, and we will go over that for fourth semester. But in the meantime, anything that I can clarify for you guys so far. So blue bloaters, the chronic bronchitis patients are called blue bloaters because their main issue is airway. There's a lack of oxygen that is able to flow through the bronchi because of the bronchitis. And so they get hypoxic, and so they get cyanotic from that. Okay. Now the other part, I'm so glad you mentioned that. The other part, that these are all infectious, what we talked about here so far, right? So the other thing that happens to the alveoli is that it loses its elasticity. Okay. So when the alveoli lose its elasticity, is it able, so two things happen. One, is it able to squeeze out the air? So there's gonna be a lack of CO2 exhalation, right? It can't go out because the alveoli doesn't have the elasticity to squeeze it out, okay? And then when O2 goes in, what happens? O2 goes in, and then, CO2 can't get out, O2 goes in, CO2 can't get out. So this becomes kind of just inflated like that, right? So what is the symptom that happens when that happens? It is called barrel chest. Right? Because the air is just trapped in, right? It just keeps blowing. You just keep kind of inflating it, right? Who gets barrel chest? I heard COPD, I think. Which kind of COPD? Emphysema. So what is the problem in emphysema? It's the lack of elasticity of the alveoli. Okay, what caused the lack of elasticity of the alveoli? The same problem in right here. Okay, so there's actually two reasons that someone can get emphysema. So again, in emphysema, so we'll say that there is loss of alveolar wall elasticity, right? So when there's a loss of alveolar wall elasticity, it's not able, so there's decreased CO2 exhalation, and then there's also going to be an increased what's called residual volume. Okay, this is a fourth semester terminology. What is residual volume? A lot of air stays there, okay? So there's a loss of alveolar wall elasticity. There's going to be decreased CO2 exhalation. There's going to be increased residual volume. So what happens when there's decreased CO2 exhalation? Then where does the CO2 go? Into the blood, right? There's going to be an increased CO2 in the blood, okay? So when there's an increased CO2 in the blood, what does that tell the brain? Breathe more, right? Because it's going to want to exhale it, right? But again, this happens constantly, right? This is chronic. So then after a while, the brain gets desensitized. So then this patient's brain with the emphysema is going to be like, there's an increased CO2. Oh yeah, that's fine. He's always like that. Right? So then they lose that CO2 drive from their medulla, right? So then when they lose that, so we'll put here, this is chronic. Let me just illustrate that. So chronic hypercapnia, right? And so loss of medulla sensitivity. So there will be no, I'll move that in a minute, increased respiration anymore. So then the respiration just kind of remains normal, right? So we'll put normal respiration. Okay, no increase in respiration here. Okay, so then what kicks in? So the next drive will kick in, right? What is the next drive that causes us to breathe? the hypoxic drive. So because of this issue here, so now the patient will relies on hypoxic drive to breathe. What does that mean? If the O2 is low, they increase their respiration. If the O2 is too much, if the O2 is high, then what happens? They stop breathing. Okay, so let's put that on there so you guys are aware. So if there's low O2 equals increased respiration. If there's high O2, that equals decreased respiration. Why is that important? Because our COPDers, our emphysema patients particularly, we don't give them a high amount of O2. They will not be on a high flow unless they're intubated, right? They will not be on a high flow O2 because if you put them on a high flow, then the medulla says, oh, you have enough oxygen in the blood. Okay, well, I don't have to breathe as much then, right? And then their respiration continues to decrease. Does that make sense? Okay, so why do we call them pink? Oh, I didn't say it yet. But these people we call pink puffer. Okay, and this is why. Because there's an increased CO2 in the blood. When there's an increased CO2 in the blood, this hypercapnia here, and this is for you guys going to 242, this is part of neuro. This actually causes vasodilation. Okay, and when there's vasodilation, just like, remember how we talked about in an inflammatory process, there's vasodilation that causes redness, yeah? That's why they're called pink puffer. Okay, now I'm gonna deviate to neuro for a minute, okay? In your patients with TBI, traumatic brain injury, and where's my third semester again? Where are you? Okay, good, great amount. In neuro, if your patient has an increased ICP, increased intracranial pressure, okay, or they have a traumatic brain injury, and their brain is swelling up, right? You don't want the ICP to increase, right? What will increase it? Vasodilation will increase it because there's going to be more crowding in there, right? So then how do you make sure that you are monitoring that ICP, that you are preventing that ICP from increasing? You're going to watch the patient's respiration. And you don't want that patient's respiration to be high or low. To be low. Because what happens when their respiration is low? What happens to CO2? It goes up because you're not exhaling it, right? So you want to monitor the patient's respiration. You want to make sure that it's normal, that it doesn't go low, because if the CO2 is low, then it's going to cause vasodilation in the brain, and it's going to cause increased cerebral edema and increased ICP. Okay? Hopefully we talk about that again when you get to because I'm sure you're probably going to forget that. Yes. So for us, non-COPDers, our first drive to breathe is our CO2 drive. So when our CO2 goes up, then we breathe faster. And you know, when we go into like a metabolic acidosis, right? What happens to our breathing? It becomes deep and rapid, right? That's because of our medulla drive to release all that CO2, okay? But in the COPD or the emphysema patients, their brain becomes desensitized to that chronically high CO2 level in the blood. And so then they don't react to that anymore. The brain doesn't react to that anymore. And so then the next drive kicks in, which is also what we have, which is the hypoxic drive, wherein there's a lack of O2, then it increases your respiration, so you get O2 in. Correct. Because if you put them in a high flow, then you're giving them exogenous oxygen, right? They don't have to work for the oxygen. You're just forcing it into their nostrils, right? So then their blood oxygen becomes higher, So then now that gives a feedback to the brain saying, oh, your oxygen in your blood is high now. That means that I can lessen your respiratory rate. Does that make sense?
Is that why?
Exactly. Yes, because again, if you increase that O2 too much, then they're not going to breathe. And then there's another complication that happens from that, right? Because of the loss of the alveolar elasticity. So this alveolar wall here, what's going to happen is if you don't exhale the CO2, the other thing is the secretions kind of start pooling in there, right? And then as the secretions start pooling, then it kind of sticks together, kind of like in bronchiectasis, right? And so the patient gets what? Oops, what is that called? When this kind of all sticks together and now it's not going to inflate anymore. What is that condition called? Atelectasis. Okay, so your pneumonia patients, your emphysema patients, they're very high risk for atelectasis. Your bedridden patients, if you're not doing that incentive spirometry, and their alveoli are not inflating, they're going to get atelectasis. So your emphysema patients will get that. Okay, I don't know how I got to that. Did I answer your question as well, or did I venture off of?
No, that did.
Okay. Yeah. Oh, the other thing that I was gonna say is, as an intervention, we have them do pursed lip breathing, right? So the purpose of pursed lip breathing is not to get O2 in, but it's to get CO2 out. Because when you're pursed lip breathing, you're using your accessory muscles to push the CO2 out. Okay, and you're kind of more concentrated on blowing it out, right? For atelectasis, it's the opposite. We want an incentive spirometer because we want incentive spirometer inhales, right? It increases our inspiratory volume. That's another fourth semester term for respiratory. Inspiratory volume, okay, or tidal volume, right? Tidal volume is the amount of air that you're inhaling in, okay? And that's why it's measured in liters, right, on that incentive spirometer. So the higher that goes, the more air you're inhaling in to prevent atelectasis, regardless of the cause. Okay, so your emphysema patient, what do you think is wrong with their immune system? Is it normal or is it pretty weak? It's weak because this is inflammatory, right? So they have this chronic inflammatory illness as well, right? And so then, because they're chronically using their immune system, they are actually very high risk for pneumonia, which is why your emphysema patients get a pneumonia vaccine at age of 50. Your older people in general, if they don't have COPD, they get it at 65. Your patients with chronic lung disease, they have to have that pneumonia vaccine at 50, because otherwise, especially if they have emphysema, they can remember this this progression here. That can happen to them very fast also. Okay. Did we answer pink puffer? Yes, we did. Pink puffer is here. Another cause of emphysema that is not very common is not because of inflammation. Let's get this inflammation here and also put that there, inflammation. But there's another cause of emphysema that is genetic. Anybody know what it is? It's a deficiency in alpha-1 antitrypsin. So a deficiency in alpha-1 antitrypsin is going to cause a decrease in what? surfactant. Yeah, and that's what I was missing here. That I wanted to put that on there. Yeah. So there's going to be a decreased surfactant, and that is what causes the loss of elasticity. Okay. The previous one? Nice. Do I have it online? Oh, OB. Okay. All right, so that goes there. Okay. But that's the cost. So this is a genetic cost. So these guys, they get COPD in their 20s, 30s, even if they didn't smoke, because that wasn't the cause of their COPD. Okay. And it's still called COPD, chronic obstructive pulmonary disease. Okay. It's just different costs. Let me see. Any other questions? Anything that I'm missing? Okay. So I added a few things on here that I want to highlight. First of all, we're still inside the lungs. So we had talked about what causes fine freckles, right? And that's typically secretions due to pneumonia or emphysema, right? That could also cause fine freckles because it's still inside the alveoli. I want to add cystic fibrosis, so that could also cause fine freckles because it's the same thing. There's secretions in the alveoli. However, coarse freckles is a different story. So if there's coarse freckles, which is synonymous with rails, what we're saying is that there's kind of this bubbly sound inside the alveoli. So this is more like boiling water type of sound. Okay, or like if you were to blow like through a straw into a glass of milk with juice, that will cause a crackling sound. So what are the things that cause rails? So it's either there's too much fluid in there, okay, or there's blood that is backing up to the lung. So let's talk about the things that could cause fluid overload first, which would cause fluid to go into the lung. And this is through third spacing, right? Because there's so much fluid in the venous system, the fluid doesn't know where else to go. So then it shifts into the alveoli. So that's part of the whole third spacing phenomenon. So what could cause that? Maybe you gave the patient too much IV, you know, too fast or too much. That could cause a fluid overload, and that could cause rales in the lungs, in the alveoli. Or maybe this patient has liver cirrhosis, and what happens in liver cirrhosis is there's portal vein hypertension. And when there's portal vein hypertension, that means that the whole venous system, again, is congested. And so then the blood backs up to the right side of the heart and then backs up to the lungs. Okay, well, not back up, but it moves forward to the lungs. End stage renal disease. So in end stage renal disease, when someone is not able to filter the fluid anymore through their kidneys, the kidneys have failed. So this is end stage kidney failure. So then the fluid overload, same thing. You have too much fluid in the veins, and then it goes into the right side of the heart, and then it goes into the lungs. Okay, or right side heart failure. Right side heart failure is also known as cor pulmonale. And what causes cor pulmonale is an issue with the lung. That's why it's called pulmonale. Okay, so cor pulmonale means that there was a congestion in the respiratory system, and then it backed up to the right side of the heart. So obviously with that, there's already congestion, pulmonary edema of some sort in the respiratory system, and so it just kind of backs up to the right side. Now, another thing that could cause rales that also comes from the right side is DVT, so deep vein thrombophlebitis, which is typically in the lower extremity of the veins, right? That dislodges. So you have a clot in the venous wall that dislodges and becomes a pulmonary embolus. So then this pulmonary embolus will follow, the venous system, which is going to go from the inferior vena cava to the right atrium, to the right ventricle, to the pulmonary artery, and then it gets lodged here in the pulmonary capillary. So once it lodges in the pulmonary capillary, then the blood that is supposed to flow is going to get trapped, right? It's not going to know where to go. So then it's going to shunt to the alveoli. Okay, so there's like traffic in this because of the clot, and so then the blood kind of disperses to different areas. So again, it third shifts. Okay, and so that will also cause blood in the alveoli. So what are the two things that cause blood in the alveoli due to, blood is left-sided heart failure and pulmonary embolism. What they have in common is because there's actual blood in there. Obviously, they're going to cough up because, because their alveoli wants to get rid of the blood. They're going to have paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea. What that means is that dyspnea, they're going to have shortness of breath. Nocturnal at night. Paroxysmal means they don't know when it's going to happen. And why that happens is because they have orthopnea. So what is orthopnea? That means that they can only breathe when they're sitting up straight, right? But really what's happening inside? Again, it's because whenever they lay down flat, especially in heart failure, the blood shifts to the alveoli. So they're literally drowning from within in left side heart failure, right? So if the left side heart failure is so bad, they're drowning from within, blood overflows into the alveoli, and so now they can't breathe because oxygen can't go through, right? So then they, if they're laying down, they all of a sudden will get up and cough, and they can't breathe. So that's PND, paroxysmal nocturnal dyspnea, okay? And when they do cough, they're gonna have a pink, frothy sputum. Pink frothy sputum, there's sputum because there's macrophages in the alveoli and blood is foreign in there. So the macrophages is going to try and engulf the blood, causing sputum. And it's pink because there's blood. It's frothy because at this point, this patient is having respiratory distress, right? So they're going to increase their respiratory rate. So then there's air that's causing bubbles in the blood. That's why it's frothy, okay? So when you hear word association, test taking strategy, when you see pink frothy sputum, you want to narrow your options to two, left side heart failure or pulmonary embolism. Okay, there may be other situations where that would happen, but those are the two more common ones. Okay, pulmonary embolism or left side heart failure will cause pink frothy sputum. Okay. As far as labs, how do we know that this is a PE? The most definitive test is a positive pulmonary angiogram. However, that is also the most invasive. So oftentimes that is not going to be done. Okay. But we'll put that there. Pulmonary angiogram, because that's how you can visualize that there is a clot in there. Okay, pulmonary angiogram. As far as blood work, here for the DVT, then we're going to see, first of all, if there's a DVT, we're looking for the signs, right? So there's going to be lower extremity, unilateral edema. What does that mean? One side only. Because it's both sides, that's probably heart failure or kidney issue or liver cirrhosis, right? If it's one side, that means that circulation is blocked on that one side, and it's probably due to the phlebitis. There's going to be warmth in that area, like all the signs of the inflammation that we talked about before, right? Pain, maybe a thready pulse, okay, in that area. We don't do Pullman sign anymore, so that's not going to be something that you guys would look at. Now in the blood work, what confirms DVT? D-dimer. So there's going to be a positive D-dimer. Oops. Okay, so D-dimer is fibrin. I'll move that. Fibrin degradation product. Who remembers me talking about this in OB? What do I use as an analogy oftentimes? Cookie crumbs. Very good. So what do I mean by that? So if you break a cookie, does it break clean? No, right? There's crumbs. So in the same token, if there's a clot, in this case, this is a thrombus, not an embolus, right? What's the difference between a thrombus and an embolus? The thrombus is stuck to the wall. An embolus is detached, it's moving. So if there's a thrombus that's stuck to the wall of the vein and then it breaks off, it's not going to break clean. There's going to be crumbs, if you will. There's going to be a trail of clues that a thrombus, a clot, has broken off of its stem, if you will, and then is now floating around. Okay, so then the D-dimer will be positive. So if you have a patient with positive D-dimer, history of DVT, and now presents with shortness of breath, cough, pink frothy sputum, and then you hear rales, then what does that tell you? That's likely PE, pulmonary embolism. Okay. Okay. Any question about that so far? Okay, so that's horse crackles or rales. Okay, so again, any of these situations, you might hear that sound. Okay. Now, if there's so much fluid overload and there's pulmonary edema, can you also hear rhonchi? Can you hear rales and rhonchi at the same time? Absolutely. Because that means that there's so much fluid, extra fluid, that it's not only in the alveoli, it's also in the interstitial spaces, it's also in the bronchi. So you're hearing like all of this rattling sound all over the patient's lungs. Okay, when you hear that, that's not a good sign. That means that there's so much overload of blood or fluid in there. Okay. So the other things that I've added here are the things that happen outside the lung. Okay. So one of the things that could happen, let me start over here, is that let's say someone has a really bad pneumonia, okay? And this happened a lot in COVID times, you know, like the first wave, Delta wave. It's, you know, because that caused a double pneumonia. Double pneumonia means it's in both lobes. It's like in all the lobes of pneumonia. Usually bacterial or viral pneumonia, it only affects one lobe first, but with COVID, it affects both lobes. And the infection and the inflammation was so bad that even the pleura of the lung was inflamed. And so when that becomes inflamed, then there's also fluid that shifts into the pleural cavity, right? There's two pleura. What are the two pleuras that cover the lungs? What are the names of the pleura that cover the lungs? Visceral, which means organ, and then on top of that is the parietal, right? So visceral pleura and then the parietal pleura, right? There should not be no space between those two, right? That should be a negative pressure, okay? So you kind of want to think of it as like an airplane, right? There should not be any air from outside going into the inside the cabin, right? If something breaks or something penetrates, so what happens? Now it kind of sucks everything inside, right? So it's kind of sort of similar concept with the pleura, right? Once it's penetrated, and that's for pneumothorax later on, but once it's penetrated, then it opens up, right? It's no more negative pressure. Now, this is a little bit different with pleural effusion. So effusion means, again, it's shifting, fluid shifting or blood shifting inside. So what causes that? Again, pneumonia can cause that. Your fluid overload that I talked about here, your liver cirrhosis, your ESRD, your right-sided heart failure, because what they all have in common is there's too much blood circulating and there's too much blood in the venous system. The blood doesn't know where to go, so it third spaces, it shifts, okay? And so if it's already has occupied all of the places inside the lung and there's already pulmonary edema inside, so then it's now gonna penetrate the pleura and it's gonna go inside the pleura. So now you have pleural effusion. How do you know that you have pleural effusion? And before I go to that, a lung mass of cancer can also do that, right? Because in the lung cancer, again, there's a mass inside the lung, and then that mass is going to cause an inflammation, and that's going to cause edema, and then the extra fluid doesn't know where to go, so it shifts into the pleura. And so when we're listening to the lung from the thorax outside, there's a barrier between our stethoscope and the lung, right? Which is the fluid. So then, like I'm talking to you right now, there's no barrier, right? You can hear me clearly. But if I go like this, you can still hear me, but my voice is muffled, right? Because there's a barrier. So same thing with the lung. There's a barrier, which is the fluid, so you can't really hear the lung sound as clear. So you would describe that as a muffled breath sound. Okay, now just because you're saying muffled, it doesn't really describe the lung sound, right? Because if there's another pathology inside the lung, you could have rails that is muffled. You understand? The rails could be muffled because they're still abnormal inside, but you're not hearing it as well because of the pleural effusion as well. Okay. Or there could be pleurisy. So pleurisy means, or pleuritis, or pleurisy means that there's an inflammation in either of the wall of the pleura. And again, this could stem from an infection that's happened inside that has spread to the visceral pleural cavity. So now once that happens, that's inflamed. So every time the patient inhales and exhales, it rubs together, right? And so that causes pain, okay? So that will cause a pleural friction rub. Now for reference, a pleural friction rub sounds like crackles. It sounds just like fine crackles. The difference is in how the patient presents, because in crackles, there's no chest pain. There's no pain when they breathe. In pleuritis or pleurisy, there is pain when they breathe, okay? And also because there's pain when they breathe, that patient's probably not gonna breathe as deeply. So you have a patient having shallow breath, maybe, you know, touching their chest, their thorax, right? And not wanting to breathe because it hurts, okay? With crackles, because of pneumonia or something that's happening in the alveoli, the patient's not gonna present like that. Make sense? And then if this patient had a trauma situation, then you could also have penetration of the pleura from the parietal side, from the outside, okay? So if this is penetrated through, let's say a stabbing wound, let's say a ski accident, a MVA, motor vehicular accident, wherein, let's say the rib cage, you know, hit the steering wheel, or the rib cage broke and then it poked through the parietal pleura, or maybe you're doing CPR on a patient, right? And then that when you finally revive them, you broke the ribs, and so now they have pneumothorax from it. Okay, so then what happens when you listen to that side where there's a pneumothorax, there's no lung there, so therefore there will be no sound there, right? There's no air flowing through there. So that's when you could use absent. So there's very limited times that you can describe the lung sound as absent. One, there's lobectomy, there's no lung there because it's been removed. Two, there's pneumothorax in that area. Three, maybe there's a very large lung mass. again, that had, occupied that area, so there's no air flowing in that area, okay? If there is pneumothorax, what are the signs? If it's very big, let's say maybe even a hemothorax in here, not just a pneumothorax, then this side of the lung will collapse, and because it's going to be occupied by all pleura, right, and blood and air. So then the trachea is going to deviate to where the air is at. So you're going to see tracheal deviation. You're going to see a flailed chest. So again, flailed chest. If the pneumothorax is on the right, then the left still inflates, the right does not, right? You're going to see a mediastinal shift. Now, you can't see this with your naked eye. This is through an x-ray, because the mediastinum is that middle part, right, where the heart is at. So then in the x-ray, you're going to see it shift, because you're going to see a pneumothorax on the side, where the lung has been pushed. So the lung is going to get pushed to the good side because the bad side is being occupied by blood or air, the pleura is, okay? And then, of course, as far as patient condition, you're going to look at the ABGs because there's no lung there. So there's going to be decreased airflow. There's going to be decreased oxygen. And so you want to look at the ABGs. You want to look for signs of distress. Okay, and then you treat that accordingly. Any questions about all that so far? I think those are the only ones that I had forgotten to add. So empyema is from the word root pyo, right? Pyo means, anybody? Pus. So empyema happens sometimes just inadvertently to some people. So that also happens in the pleural cavity, okay? So in the pleural cavity, I wanted to see like a more yellow one. There you go. So it looks like pus. So you have like this area here. So it's kind of like an abscess, but in the pleural cavity, okay? That's empyema. And so they will get this pus area. Typically it happens to people who may be like exposed to a lot of bacteria all the time, meth users, opioid users that are injectable or even inhaled, your people who suffer from homelessness, or people, again, who live in like areas, maybe there's a lot of bacteria. There might be a little bit more prone to these situations because they could form abscesses in their bodies because of the bacteria, okay? And so same thing. So that empyema, it could be without any signs of inflammation. It's just there. And then you'll, again, you'll hear the pleural effusion kind of sound, muffled breath sounds. As it gets bigger, it's going to push on the lung. So it's almost like they have a pneumothorax, but it's not a pneumothorax, it's an empyema. Sometimes if it's small, there really is no symptom, unless, it's like a finding in an x-ray. Yeah, so this is kind of the same as someone who gets like a brain abscess or a liver abscess, kind of similar situation. All right, you ready to talk about intervention so we can move on to perfusion? Okay, where to begin? Let's start with anything that has to do with inflammation so that we don't have to plug that in there. So we know that if there's an inflammation, we're going to give a what? An anti-inflammatory, right? So when we give an anti-inflammatory, yeah, so we're giving steroids. Okay. Now steroids, let's be technical a little bit. What are steroids? What is say that again? Hormones, yes. What is the name of the hormone? Because we're giving here exogenous steroid, right? This is not our own steroid, right? So this is exogenous steroid. So what does it have inside it? Glucocorticoid and mineralocorticoid. Now, that's not all the time, right? There might be different formulations depending on different steroids, right? But this is what they will have, okay? So the glucocorticoid, that's the anti-inflammatory part, right? That's cortisol. That's your stress hormone, but this time we're giving it as a medication, okay? We'll talk about like side effects later on. But let's look at different forms. So different forms. Let's start with something local. So it could be a topical, but it doesn't apply here. So we're not going to add that, but yes, but maybe a nasal spray, right? So something that you use for like allergic sinusitis, chronic sinusitis, even like acute sinusitis infectious, you could still use the steroid spray, right? So that's local. And then we can go a little bit more bigger, and we can do a metered dose inhaler, right? So that's the one that you spray through the mouth, right? And then you have to inhale and hold it. So not so much for steroid, but you can. And then we can also do something that is more positive pressure. Let's put positive pressure, which is your nebulizer, right? So what's the difference between something that you inhale versus a nebulizer? Something that you inhale, you have to literally inhale, right? With the nebulizer, you breathe just the same way that you're breathing, and then you have like this mist that's being blown into you, right? So that's a nebulizer. Or now, if this is more systemic, so then now we're getting into either PO form, right? Tablets, pills, PO, either tabs or liquid. Or if it's even worse than that, we can do an IM steroid, or if it's extremely bad, we do IV. Right? So this will be like your Solomedrol is like a typical steroid that we would give, right? As an IV. So what does that tell us? The more systemic the route, the worse the inflammation is, right? But we're not going to give an IV steroid for like a new onset asthma, right? Unless it's like really, really bad, okay? So long term, if you have your patients who are taking steroids, for example, you have a patient who has asthma exacerbations all the time, right? Because this is inflammatory, we want to give an anti-inflammatory. So especially with kids, they could be on steroids for months, right? So FYI, in kids, steroid has been found to stunt their growth because your steroid, your endogenous steroid, where does it come from? Yeah, where does it come from? Which gland? Okay. Adrenals, right? Your adrenal gland. What other hormone comes from your adrenal gland? Which is mineralocorticoid. What else? Growth hormone. Okay, so think about this for a minute, right? Adrenal gland produces growth hormone and steroids. But now you're giving steroid that is exogenous, right? So your patient is getting a supply of steroid from the outside. What is the adrenal gland going to do? It's not going to produce any more steroid, right? What is it also not producing? Growth hormone, right? And so that kid that could have grown 2 more inches is not going to get that 2 more inches. So they're going to be shorter because it also stunts their growth. Okay. And over time, if this is pills, it's glucocorticoids, so it increases sugar, right? So they can get diabetes. If they have mineralocorticoid, which is aldosterone, that's going to absorb fluid. And so what are the signs and symptoms of someone who's on long-term steroid? They have Cushing's syndrome, right? What is Cushing's syndrome? So that's when they have, let's characterize Cushing's. They have the moon face, their buffalo hump. What buffalo hump is like, they have like this fatty area in the back. They're gonna have weight gain because of the fluid and the increased adipose tissues. Why do they have a lot of adipose tissues? Because they have a lot of sugar. Why do they have a lot of sugar? Because of the glucocorticoid, right? And they're gonna be at risk for infection, okay? So people who are on long-term steroids will have these issues. What are our patient teaching for someone who's on steroid? If it's a nasal spray, you want them to spray it away from the bridge of the nose. Why? It could cause a perforation of their cartilage because steroid will actually weaken your cartilage if you use it chronically. Okay, so they have to spray away from the nose because otherwise, if you keep spraying it this way, you're gonna weaken the septum and you could perforate it. Okay, in the mouth, we ask them to rinse their mouth, right? Because they're gonna have fungal infection, candidiasis, right? Oral candidiasis or thrush. In PO, as much as possible, we want to avoid giving it towards the evening time. Why? It causes insomnia. Okay, because cortisol is a what is the term for day and night? Sorry, thank you. Circadian, right? It follows our circadian rhythm, right? So when we wake up, when the sun rises, the cortisol rises. But if you give it at night, that means your patient's going to be awake. Okay. If you're giving it as a PO, especially liquid to kids, is very, very bitter. And you are risking high non-compliance because it doesn't taste good. So for peds population, as long as the patient is not allergic, you can ask mom to like maybe get a teaspoon of honey or a teaspoon of like Hershey syrup, or Nutella, peanut butter. Put that in a, have them lick that from the spoon. Don't rinse the mouth. Then take the medicine while their tongue is coated with that. That way they don't taste the medication. Okay, for kids. So again, any of our patients who have the itis, right, will have the steroid. Okay, so that's a given. Now let's look at something more specific. So for the epiglottitis, it may need more than just steroid to decrease this inflammation. So what is better than steroid that decreases the inflammation? Epinephrine. Okay, adrenaline. So anytime you have, and this is true for croup as well, anytime that there's like severe inflammation, and you can kind of just remember, well, not in epiglottitis, in croup, we have our stridor, right? That can also use epinephrine if it's really bad, okay? Because what does epinephrine do? Vasodilate, vasoconstrict. So when you vasoconstrict, you're decreasing the edema, right? Because we remember in inflammation, we have vasodilation. So you reverse that, you vasoconstrict, you're decreasing the inflammation, you're decreasing the edema. It's also antihistamine. So you're decreasing again the edema and the swelling. What else? Is bronchodilate, right? So it opens your airway. Okay, so that you want to reserve for like, a really emergent situation. Okay, not everyone gets epi. Only those really bad cases of croup or epiglottitis where there's like, really bad inflammation. And of course, for this patient right here, like we mentioned earlier, you can't really shove a tube in there if it's already blocked, right? So then what's going to happen? What does this patient need? You're going to need to, well, the doctor is going to have to put a tracheostomy. Okay, so what is your job? What is your nursing responsibility if your patient has epiglottitis and croup? You want to make sure that there's a tracheostomy kit, not a trach care kit, a tracheostomy kit at the bedside for emergency situation. Okay, so that they could open the trachea and put a tube in there. Okay, if necessary. Okay. Your bronchitis patients. So we've mentioned here viral, fungal, bacterial. So obviously, if it is, let's go with viral first. If it's a common virus, do we give anything? No. What if it's flu? If it's flu, we can give Tamiflu. If it's COVID, we give Paxlovid. Okay, so for your viral, if it's flu, Tamiflu. If it's COVID, Paxlovid. Okay, if it's bacterial, then of course we're going to give an antibiotic, right? Usually, not all the time. They start with azithromycin. This is just informational, but it's just antibiotic nevertheless. Or Augmentin if they need something stronger. Okay, Augmentin is broad spectrum. Okay, and then fungal. What are your medications for fungal? Those very good. Yeah. So fluconazole is an example of antifungal. So when you start seeing like IV fluconazole, that's not good, right? That means that this patient has a really bad fungal infection. Now, if they have a fungal infection, what will you not give that we had talked about? Like, again, this is respiratory, huh? Very good. Why? Yeah, it's going to worsen it, right? Because it's a fungal infection. So you're just going to cause more fungal growth. Okay, excellent. Very good. Okay, now in our chronic obstructive, your COPD patient, there is a mainstay of their treatment. So again, this is in the bronchi. It may cause some constriction, some narrowing. There's also some secretions. And so there's a category, there's a class of medication that we usually give for our blue bloaters. Anybody know? Anticholinergic. Anticholinergic. That is going to be an inhaler, okay, or a nebulizer treatment. So this could be Atrovent, Ventolin, ipratropium bromide. Okay, these are anticholinergics. Now, if we're giving an so these are like more of like nebulizer, inhaler, right? If we're giving an anticholinergic that is PO, can you give me an anticholinergic that is PO? Usually given for like cough, like a cough syrup. Promethazine. Patients like, I want the purple one, not the green one, because the purple one has the codeine. We don't need the codeine, just promethazine, okay? So promethazine is an anticholinergic. So what do anticholinergics do? What is our main goal here? Bronchodilation. Okay, and yes, it dries up secretion as well because it's anticholinergic. Not one of the best things to give when someone has emphysema though, yeah? Right? Wouldn't that make sense? Because we don't want to dry that secretion that's there, right? We want to get it out, okay? But your chronic bronchitis patients, this is one of the mainstays of their treatment, okay? And then here for our asthma patient, what are we going to give? Okay, let's classify that. So we're going to give, here's asthma, and actually, hold on. Let me clarify that. So we have the inflammation here, and we know we're going to give the steroid here, right? Let me just put steroid here. So we are specifying that. Because we already talked about steroids, so we're not going to talk about that anymore here. But what else do we give, did you say? Albuterol. And what is the purpose of albuterol? Bronchodilation. What class is albuterol? Beta adrenergic agonist. So what does it work on? This one right here, right? So then we're going to give beta adrenergic agonist, right? So your beta adrenergic agonist, what is the main purpose of the beta adrenergic agonist? We already said bronchodilation, right? But because this is a beta adrenergic agonist, then what are our side effects? Tachycardia, what else? Anxiety, very good. Hypertension, especially in your a lot of the COPDers, right? They'll have their rescue meds and they're always short of breath, so they're always like every hour, right? Too much. So then they come to the clinic with their blood pressure in the 170s, and you're like, why is your blood pressure so high? I don't know. It's because they're like, they keep spraying their albuterol because no one has taught them how to use it. So technically speaking, there's two kinds, right? There's a short acting and a long acting. And that's where the SABA and the LABA comes from. So SABA is short acting, LABA long acting. Can you give me the names? Can you give me an example of a SABA? Albuterol and levobuterol. Sopanex. You heard of Sopanex? So that's short acting. So these are known as your rescue medications, right? So meaning they should only be used as rescue med, okay? Only when there's shortness of breath. The maintenance medication should be what? Steroid. Okay, maintenance. Maintenance medication for inflammation is the steroid. This is just a rescue medication, okay? Now, the newer medications will have a LABA, a long-acting beta adrenergic agonist. Can you give me some names? Say again. Salmeterol and formoterol. So these are kind of longer acting. They say that it's actually not, you might need to correct me on this, but I think it's chronic asthma that you shouldn't give some long acting. I think one of them causes death. Yeah, it is the chronic asthma. It's that you give this mostly for your bronchitis patients, your chronic bronchitis patients. Okay. So we have our beta agonist, and then yeah, so you can give a mast cell stabilizer. You can give theophylline, right? But those medications are kind of on the older generation, and so they're not used as much anymore, but they're still there available. For our pneumonia, same thing, right? If it's viral, bacterial, fungal, the same medications that we gave earlier, we'll give here. When we get to our ARF, and you know that this is the patient is declining, then we know that we are going to, this patient is going to need to get intubated, right, and ventilated. And they're going to be on an induced coma, right? Because you can't put a tube on a conscious patient. They will fight you. Okay. So then you have to put them on an induced coma, put them to sleep. So basically, what do we give? Some paralytic, okay, and then a sedative, so that they are also asleep. You intubate them, you put them on a respirator, a ventilator, until they get better. Okay. And then for our PE, what do we give for PE? What is the first drug of choice? That is a layman's term. Give me the correct terminology. No? No? There you go. Thrombolytic. Give me a thrombolytic. Very good. So your TPA, right? Alteplase, streptokinase. And then yesterday we talked about what? Heparin. So now what is the purpose of the heparin then? Why are we giving a thrombolytic then also giving heparin? So it doesn't back up, right? So then now you're going to give an anticoagulant. So keep in mind that a thrombolytic is not an anticoagulant. There's two different classes, right? And a thrombolytic only works after a few hours of the onset, right? Because it's TPA is tissue plasminogen activator. Plasminogen is the enzyme that activates plasmin. Plasmin is the enzyme that you have that breaks down a clot. But if it's been there for too long, that's not going to work anymore. Okay, you're still going to give an anticoagulant. So usually heparin, drip, right? That's when we do that heparin protocol, okay, to prevent more clots from happening. Okay, and then they may consider embolectomy. Okay, through an angiography, pulmonary angiography. Okay, if they can't melt it with the thrombolytic anymore. Okay. For your left side heart failure, we'll get to that when we get to the heart. For these people with fluid overload, let's just add like some things on here that will be beneficial as well. What do we give for these people? Okay, and what is that going to do? Give me the class. Diuretic, loop, diuretic. Okay, specifically loop diuretic, right? Not hydrochlorothiazide, but you can give spironolactone, by the way. But the main option is a loop diuretic, which is, what is the generic name? Furosemide. Will you give furosemide if there is end-stage renal disease? No, it's not going to work, right? There's no more functioning of the kidney. Okay. So that's the only condition that you probably will not give that for. What about your pneumothorax? What are we going to do for that? Test tube. Yep. So this requires a chest tube. insertion. What about your pleural effusion patient? What is the difference between a chest tube and a thoracentesis? They both drain. So you can kind of think about this as you think about catheters, like urinary catheters, right? So a thoracentesis is like a straight cap in and out. A chest tube is like an indwelling cap because it stays there. Okay, this, you poke a hole, you drain, you remove. But they do the same thing. Okay, commonly you put a chest tube if there's a large area that needs to be drained, and it can't be drained just in one in and out, you know, it takes days or weeks. Also, for semester, if your patient, let's say, has hemothorax and pneumothorax air, where would you expect a chest tube for pneumothorax to be placed? Lower or higher? Where would you expect a hemothorax to be placed then? Lower. So hemothorax will be lower, pneumothorax will be higher because air rises up by gravity, okay? So if they have both, like you know, sometimes in the ICU, you see like a person with like 4 chest tube drains, right? So the lower ones drain like more fluid and blood, and then the upper ones will drain air. Correct. If they have both. Yeah, okay. Pleurisy, pleuritis, anti-inflammatory. Yeah, pretty much. Oh, good question, actually. Let me add something there. So remember how I said this patient here has a lot of pain, right? So how could you address the pain? Give them what? They would need a block, a nerve block. Good question. Why would you not give a narcotic? What are they not doing? They're not breathing. Why? Because it hurts, right? So if you give them a narcotic, they're gonna breathe even shallower, right? So that's why you don't give a narcotic, but that's an excellent question of what not to do. Thank you. But no, really, because if you didn't bring it up, I would have forgotten to say it, right? But you give a nerve block because that way you block their brain from sensing the pain. Did it remove the pain? No. The inflammation is still there. The pain is still there. You give us an anti-inflammatory for that. You give antibiotic if you need to for that. But you block the pain. You give an injection in that area where the pleuritis is. That way they don't feel the pain and they can breathe better. And they can inflate their alveoli better. Because if you don't, then what are you going to have? Pneumonia, right? So yeah. Okay, anything else? And so the nerve block is just the route, the form. And we're giving commonly lidocaine, bupivacaine. Sometimes you might even throw in a steroid in there. So any type of the steroid that the provider likes to use, they can do that as well. So what is the cause of the, are you talking about the ABG imbalance? Yeah. So then what do we do to remove the CO2? Intubate, ventilate. Yeah. Now, if the cause of the CO2 is like a blockage in the alveoli, again, it boils down to anti-inflammatory. Oh, for your cystic fibrosis, where's our cystic fibrosis guy? We give, so this is a whole thing. Let's enumerate that. Okay, so let's start with medications. So number 1 medication, we're gonna give them mucolytic. Okay, mucolytic because the mucolytic destroys breaks down the mucus, right? This would be commonly a Dornase alpha. Okay, could be Mucomyst. Eucamist is a N-acetylcysteine. This is the same medication that is used as an antidote to Tylenol overdose. Okay. Just, you know, fun fact, it is also now used in depression and yeah, mental health and anxiety. Okay. Now, once you've broken down the secretion, then now what are we going to do? Going to expectorate it, right? So now we're going to give an expectorant. And what is an expectorant? Guaifenesin. Okay, Robitussin, but Robitussin is a brand. There's different generics. You want the guaifenesin. Okay, you do not want to give a antitussive. Okay, what is an antitussive? Codeine. Okay, even promethazine has antitussive. You don't want that. Okay, you don't want anything that has DM, dextromethorphan. Because dextromethorphan, did I spell that right? Yeah. Dextromethorphan also is an antitussive. Okay. Again, fun fact, dextromethorphan plus Wellbutrin is good for anxiety. Combined together. All right. So that's medication wise. And then of course the for inflammation, the steroid, right? But we're also going to do CPT. So chest physiotherapy. What does this entail? The first thing that we're going to do is we're going to liquefy the mucus. How are we going to do this? We're going to give either increased fluids, PO, or we're going to do normal saline nebulizer, okay? So that the patient's mucus gets a little bit more softer. Secondly, we're going to do percussion, okay? You know, we're going to loosen get the secretion off of the wall of the lungs, okay? Your CF patients even gets a percussion vest. It vibrates. Correct. That is, yeah. So that's the same thing that happens with a percussion vest. So it just kind of like, you know, yeah, because what that does is it, you know, gets the secretion off of the wall of the lungs. And then they can do postural drainage. Right? So basically postural drainage, the area of the lung that has the most consolidation, you bring that the highest, right? So that by gravity, you can even do the percussion at the same time. You're kind of draining it out, okay? And if they can't do that, then you can do a pulmonary toileting. So what is a pulmonary toileting? You know, you flush the mucus out, right? How do you flush the mucus out? Suctioning. Okay. If they can do TCDB, turn, cough, deep breathe, that's great. That's why you always want to encourage deep coughing. But if they can't do that because you're too frail and weak, then you need to suction. This is going to need to be done for your CF patients, every 1 to 2 hours, round the clock. Okay, until they don't have any more secretions. Okay, so that's the mainstay of that. You can certainly do that for pneumonia as well, if there's a lot of secretions or maybe a sick emphysema patient, okay? But it's most aggressive in a cystic fibrosis patient that you would do that for, okay? Oops. Questions? BiPAP. Your BiPAP, you can do a BiPAP for your ARDS patient. Only if they have like apnea. Yeah, if they have like apnea, as a comorbidity, like maybe they're obese or, like, a lot of obstruction here, like sleep apnea, obstructive apnea, then they'll have a BiPAP. Or if they're weaning off of when you're weaning off of your tube. So from a ventilator, then they're gonna go into a CPAP and then, a BiPAP and then a CPAP. And so you're kind of allowing the patient to gain more strength and more independence in breathing. So you don't just pull the tube and then you're done, right? You kind of want to sample to see if, they can tolerate it.